I think that eventually testosterone would be used to help people's health issues unrelated to their blood level. I think we will come to realize,
That's a bold statement.
like prednisone,
Yeah.
like steroids,
Yeah.
like non-androgenic steroids.
Glucocorticoids. Yeah.
Yes, that they will find uses that are not dependent on blood levels. That's what I think.
Yeah.
And I also think that it's inevitable that peptides will be allowable, that pharmacies will be allowed to make them.
What is up, guys? Dr. Alex coming to you, and I am so excited to have my eternal mentor, my friend, and really the man that inspired me to pursue men's health with us today, Dr. Larry Lipshultz. How you doing, sir?
It's good being here.
So we're currently at the Sexual Medicine Society of North America meeting. This is
You love it.
Oh, it's the best, right? It's an excuse to like hang out with like all of our friends, right? You know, people that we don't see, very commonly.
Right.
And, for obviously like, everyone who's in medicine understands this like training pathway, but can you just explain to our audience, like what is a fellowship and like what's the purpose of it and how did someone with your reputation end up getting stuck with me however many years ago?
Well, I chose you.
That is true. Yeah. That is true. So
to back up.
Okay.
So to become a doctor, you have to go to college. Understood.
Yep.
Medical school. Understood. And then you pick a residency. You pick a specialty. So you picked urology.
I did.
And I don't know, your program was 4, 5, 6, how many years?
Oh, it's 5 years.
5 years.
Yeah.
So when you get to start near the end of your program, you start deciding, well, what area do I want to go into? Because urology has a lot of sub areas, like, cancer, oncology, women's issues,
That's a separate thing.
pediatrics.
Endo, yeah.
And then there's a whole area of male reproductive medicine and surgery, or sex med, whatever you want to call it. And that's the area that you decided you wanted to get more training in. So the training beyond a residency is called a fellowship. And you chose to do a fellowship. So to do that, you need to look at the fellowships around the United States, decide where you want to go, and interview. And that's how we met.
Yeah.
Because you interviewed with us, Baylor College of Medicine, and I picked you to be one of my 2 fellows.
Yeah.
And it was a good choice.
It was, you know what, it turned into one of the best years of my life.
Yeah. Me as well.
It was a lot of fun because it was, the 2 of us and then my ride or die co-fellow for life, John Balin, who's still one of my best friends to this day.
It's so interesting how it's a 2-person fellowship for people, and how 99% of the time, these 2 total strangers become best friends forever.
Yes. And
I've had actually 2 instances. One instance, they did great until the end.
Okay.
And then one of them decided to practice where the other person thought was too close to him. So he stopped talking to him. So that was the end of that. And then I had 2 fellows where one did not talk to the other directly for the year.
That must have been a hard year.
I just did not get into it,
Yeah. Fair
it was
enough.
between them.
Gotcha.
Anyway, so you've completed a fellowship and then rode off into the sunset.
Sunset to practice medicine and make YouTube videos.
Yeah.
So my question for you is, do you know how many fellows you've trained off the top of your head?
No. It's over 100.
Oh, easily over 100.
Yeah.
I mean, you've got to be like over 130 or 140.
No, I don't know. But the reason why it gets confusing is there was a time
Yep.
when we were taking a fellow in the lab and then 2 fellows clinically.
Yep.
So when we did that, we would have 3 people a year.
And we had 4 briefly whenever I was there because Nanan and Scott were both there.
Right. So we had 2 people overlapping in the lab.
Yep.
And then you were and John were clinical.
Yeah.
So that's how the number got so high for the number of years we've done it.
Yeah.
Some years there were multiple people above 2.
But I think that we can say, like, with absolute confidence, I mean, you have the most prolific fellowship in urology, period.
I do.
Yeah.
But I started when I was 12.
That is true. Absolutely. Yeah.
We have to remember that.
Yeah. You were a young prodigy.
I was very young.
Yeah. And one thing I wanted to ask you is, so whenever you were going through residency, I mean, number one, fellowships weren't a thing, really.
Right.
And also,
I never thought about it.
yeah, right. But male fertility and male sexual medicine, that didn't really exist as a subspecialty.
Right.
And so, how did you go from being a resident, doing mostly general urology, and all of a sudden you end up down from Pennsylvania originally,
Right.
to Texas,
Right.
and kind of developing this field, authoring treatment of the infertile male,
Right.
and starting.
Well, it's an interesting story.
Yeah.
So it starts when I was a first year resident,
Mhm.
which was the same as being an intern.
Mhm.
And we had to rotate on several different subspecialties. And I was on OBGYN as a resident. I think it was maybe 2 months. And we had grand rounds. And somebody came from New York, a PhD, who was the person who knew more about sperm than anybody else. And he gave this lecture to the gynecologist. And I happened to be in the audience because I was rotating. I was a urology resident.
Yeah.
And the man said, I know. So he gave his talk.
Yep.
And then the chairman stood up and said, that was a great talk. We're moving into IVF, and we just have no urologist to see our male patients. And he said, hopefully someday we'll have, but right now that's our biggest deficit. And he said it because the man had given a talk on sperm.
Yeah.
And so I'm in the audience and boom, a light bulb goes off. Wait a second. So I'm just getting into this specialty, and there's a big opening for urologists who are interested in taking care of infertile men. That's what I should do.
Yeah.
Right. So the next year your second year was your lab year. So I went to the lab and I devoted the entire year to learning all I could about male infertility, which was not much at the time. Went to New York a couple times, met with people there who were like doing things in the field. Came back and I had a year, started a lab using my nurse who was lent to me 1 day a week by the chairman to work with me, seeing patients, and we both learned how to do a semen analysis, started seeing patients, and I would see patients once a week. And
this is as a resident.
As a resident.
As a resident, you had your own fertility clinic, which did not exist as a specialty.
I know.
As a resident.
You're right.
Yeah.
And I would admit people for surgery under the gentleman, Alan Ween.
Yeah.
Who was very famous.
Yeah, Alan,
Yes.
who wrote Campbell's.
Right.
Yeah.
And then so he would go to the operating room with me, but they were my patients.
Yeah.
And we would do varicocele repairs, or I did not do vasectomy reversals back then, sperm extraction or whatever, because just getting into IVF.
Yeah.
So that's how it started. And then I got pulled out for 2 years to go to the military. And I started a male infertility practice
in the military.
The first one, right?
Yeah.
I was there for 2 years, come back, finished my residency. And then at the end of my residency, they were starting this new thing called the AUA Fellow, which is now Urology Care Foundation Fellow.
Yep.
And so my chairman, who was moving at that point to Texas to be chairman at the new medical school in Houston, said, listen, you should apply for this fellowship. He said, it's the first one.
Yep.
So I applied for this fellowship to spend 2 years studying male reproductive medicine, because there was a fellow basic scientist / endocrinologist at the University of Texas who was in that field.
Yeah. And we have to clarify for our audience, this is very different than my fellowship.
Yeah,
This is basically an educational grant, just giving you the money to live and do research to advance your own knowledge.
Yes.
This was choose your own adventure.
Yeah, it was a research fellowship.
Yes.
Sponsored half by the American Urologic Association and half by the organization I was going to, which was the University of Texas.
Yeah.
But I was also an assistant professor of urology. So I would spend 4 days in the lab.
Yep.
1 day I would start seeing patients.
Wow.
I know.
That's a lot.
Yeah, but it was great because you got to remember, nobody else knew anything about infertility.
No, of course not.
So to be one of the first ones to kind of get into the area,
Yeah.
People say, oh, how you do it, it became so well known. Yes, but there was nobody else.
There's nobody else around.
Right.
Yeah.
It was just a very smart decision without really being smart. It was a decision I kind of made because there was an opening.
Yeah.
And I thought, hey, I'll get to know more about this than anybody else.
And tell me when did you finish the Urology Care Foundation fellowship?
Like 78,
78.
79.
Okay. And then when did you take your first fellow?
About 85.
85. Okay.
But I didn't take a fellow
yeah.
because I knew anything about a fellowship. I didn't take a fellow because I wanted to start a fellowship.
Yeah.
I took a fellow because my friend at the time, who was chairman at the medical school in Canada, a medical school in Canada, contacted me and said, hey, listen, Larry, I've got a fellow here. He's great with his hands, great with microsurgery.
Sure.
But no one up here is doing vasectomy reversals, which I had started to do.
Yeah.
He said, can he come down and train with you for 6 months?
Yeah.
So that was my first fellow, but I did not initiate it. He initiated it.
So for the sake of our audience, I just have to clarify some things. Like, Dr. Lipshultz was...
But do you think anybody cares?
I think people should. You invented the field.
I mean, you care.
No, well, obviously,
it's very niche.
It is niche, but if you think about, like, look how popular things have become when it comes to testosterone replacement, wellness, trying to live the best version of your life, and all of that medicine actually started with what you were doing.
Well, it started with male infertility.
Yes.
And then people got more interested in men's health.
Yes.
Which then became erectile dysfunction.
Yep.
Testosterone replacement therapy. And here we are today.
But it all
We're at a meeting devoted to that area.
Exactly. And what I find fascinating is that...
But you got to so much of it was being in the right place at the right time.
But also doing the work, right?
Yes.
It could have been easy to have chosen you could have chosen the easy way out at any point in time and just done kidney stones or something like that.
Yeah. Can you imagine today if you were the only one who knew about what you're doing?
I could not.
I mean, they're asked to give lectures every place, asked to write things because you're basically the only one.
Yeah, it was you. It was
me.
just you. Yeah.
Yeah. So it was exciting.
That is, it is a singular story that I don't think that, we've seen anything equivalent to it in urology.
And we probably won't because now everything's kind of, the areas are all...
It's more saturated.
Yeah.
Yeah. And, and then we have, because you've trained, so many fellows, right?
I do.
You have so many people who now specialize in it because of, what we heard from you.
Right.
But, like I was saying, like for the sake of the audience, so many things that we take for granted today, which is vasectomy reversal, the ability to start a family after, a life change, the ability to get sperm back into the ejaculate after being on testosterone, the ability to give testosterone to patients that are, potentially at risk for prostate cancer, even have prostate cancer and active surveillance. All of this, the entire field of male fertility that we all take for granted, that has been the setup for health and wellness, that all started with you.
Well, I mean, some of it didn't start with me, but I certainly took the ball and ran with it. I mean, the thing like the whole area of cancer is not my thing.
Yeah.
But I kind of fell into it.
Mm-hmm. So, like, for example, like vasectomy reversal, again, wasn't really a thing whenever you first went into practice.
Right.
So I know you've told me this story before, but tell me about your first vasectomy reversal patient and what that conversation and what that surgery was like.
Yeah. So I was starting to do vasectomy reversals in the lab. I was practicing. And I was not the only one in the country doing it. There was another guy doing it up in St. Louis.
Okay. Is that Silver?
Yeah.
Okay. Yeah.
So but I was at Southwest, Texas, whatever.
Yeah.
So I practiced in the laboratory.
Yeah.
And then one day, my chairman came to me and said, hey, Larry, I've got this couple and they want a vasectomy reversal. Can you do it? I said, I think I can do it.
Yeah.
I haven't done one yet. So
sure.
They came to me and it was a kind of to be a blended family because he came into the marriage with 4 children.
Got it.
Right? And she had never had a child. He had had a vasectomy. So I reversed his vasectomy.
Yeah.
Right? And then I started getting Christmas cards with pictures of the new kids.
Oh.
But what they would do is the initial family would be in green.
Yeah. And
the new kids would be in red. So each year, I'm not exaggerating.
Yeah.
Each year, the number of kids in red increased, and until it got to 4.
That's
so they
to match the original.
I don't know why.
Yeah,
but they ended up with 8 children, 4 from the reversal, 4 from prior to the visit.
That's wild.
I know. And I saw them for years.
Yeah.
And in fact, I still see her occasionally. She comes to see me.
That's cool.
I know.
And you told me, like, right now, whenever you do a vasectomy reversal, the standard is using a big operating microscope, using these tiny little teno sutures.
Right.
For our viewers, the bigger the number is, the smaller the suture. A teno suture is smaller than a
Piece of hair.
Yeah, exactly.
Smaller than a human hair.
Much smaller than a human hair, and the needles are just, you sneeze at them wrong, and they'll bend.
They fly away.
They fly away, and we're never gonna. Yeah, exactly. And so that's where the standard.
But wait a second. So I've got, in thinking back.
Yeah.
Okay. The first one I did was not with a microscope.
I know. That's what I was gonna ask you. Like,
the first one I did was with loops.
Yeah.
Magnifying loops.
So
I started off, they were 3 power,
Mhm.
right? And then I went to, I think, 5 power.
Yeah.
And then I went to 8 power.
At that point, you just have like a telescope falling
So
off your head.
They're this long.
Yeah.
And you cannot move your head.
No.
Because because you're establishing the focal length.
Yeah, yeah,
So after about a year with that, my neck was gone.
yeah.
I said to the chairman, I said, I can't do this anymore. We got to get a microscope.
Yeah, yeah.
So we got a microscope, and it made my life so much easier. My neck stopped hurting.
Oh man.
I know.
Yeah.
And I think I did a better job because I could really see so well.
Got it. And so your first fellow was sent to you specifically for your vasectomy reversal technique.
Yes, but not for the microscope. We didn't have the microscope.
Didn't have.
Oh, no. I think when he came to see, yes, I had already started doing them.
Mm-hmm.
And so I did have a microscope. When he came to see me, it was a microscope.
So I want to talk about some of the major seminal moments that you've had in your career, some of the things that you've helped develop. And so I want to ask, obviously, much respect to Abe Morgenthaler, who has been a fantastic colleague to you and has been, one of the progenitors of testosterone therapy in the modern era.
Right.
But, the first idea of being able to keep patients on testosterone while they were on active surveillance or treat high-risk patients, that was y'all's paper. That was something that you did together.
Yes.
So what did that conversation look like? At what point were you thinking, like, maybe we can actually preserve these guys' quality of life? Because the old dogma was like prostate cancer and testosterone do not mix.
Right. So it was kind of like serendipitous.
Yeah.
So I had, Baylor College of Medicine, the whole Texas Medical Center, big oncology focus.
Yeah.
Big prostate cancer focus.
Yeah.
So I would start getting these patients who had prostate cancer and had their prostate removed, and but nobody would give them testosterone because they felt, well, if there were some cells there, maybe they would grow.
Yeah.
And then there were other people who were actually on active surveillance, meaning they had very low stage prostate cancer, but not enough where they actually required surgery. So I don't know why, in retrospect, they did it. But they were so needy. They really were so symptomatic of low testosterone that I did give some of them started giving them testosterone.
Yeah.
Right. So then I at the time I was running a yearly conference with a Morgenthaler.
Yep.
And we started talking one time, and I said, I'm having this fascinating experience giving patients with active surveillance testosterone. He said, "Oh, you're kidding." He said, "I'm doing the same thing." So that was the history of that first paper. That's when we pulled our patients and wrote the paper.
I'm remembering an earlier conversation that we had today where we were discussing a colleague of ours that practices very defensive medicine.
No names.
No, of course not. But, I remember that conversation. And whenever you told me that story about, you cared about your patients so much, you were willing to push the envelope to be able to improve their quality of life. I mean, really, that's how medical innovation, starts. That's how it happens. You have to be willing to step outside your comfort zone to try and offer patients something better than what is out there today.
Right.
And so I think that it speaks to how being willing to push boundaries is actually a good thing for patients, because you're willing to think outside the box and try new things to get them what they need. And along that vein, what was your thought process whenever you were first trying to treat men who were azoospermic, so had no sperm in the ejaculate from testosterone therapy, or were trying to regain their fertility? What did that look like?
Yeah. So for the audience.
Yeah.
So what happens when men take testosterone, they turn off the stimulatory hormones from the brain.
Yep.
That make you produce sperm.
Yep.
And without those stimulatory hormones, you don't make sperm. I mean, some people are born without those hormones. But, most healthy guys have the hormones. But if they need testosterone, because their testosterone is low. They would take it, but those hormones would be turned off and they wouldn't make sperm anymore.
Yeah.
So very fortunate. I was working with a compounding pharmacy who I still work with, which is a fantastic pharmacy called Empower. We got to give a shout out.
Absolutely.
To Empower Pharmacy.
Shout out to Sean.
Sean, yes. So they were making FSH, compounding FSH and HCG, which are basically the two hormones that testosterone turns off.
Yes.
And why people didn't take it prior, and for one reason, among other reasons, is it was so expensive.
Yeah.
The brand of these separate hormones, hundreds and hundreds of dollars.
You have to take out a second mortgage on your house.
Too.
Yeah.
But Empower Pharmacy was making them.
Mm-hmm.
So I started using compounded FSH and HCG for these men whose sperm had been turned off due to testosterone.
Yeah.
And initially, we stopped the testosterone, right? And we gave them these hormones, and lo and behold, their
sperm came back.
Because if you think about it, it's only logical. If you give them the hormones that they don't have, then it should come back.
Yeah.
So fast forward maybe 15, 20 years of doing that, kind of decided, now, wait a second, it's not fair. These men are so symptomatic.
Yes.
Because they started out with low testosterone.
Even on the HCG, their testosterone's going from here
It's
to
not
here.
good. Yeah, it's not going to be where they feel good. It's
Exactly.
not in the feel good zone.
Yeah.
So what I started doing was giving them testosterone because I thought, look, wait a second. Testosterone turns off these hormones.
Yeah.
We stop the hormones. I give them these hormones. Why can't we give them back their testosterone?
Yeah.
So we started giving them back their testosterone, and they did exactly the same as the men who stopped the testosterone.
And I know you recently published this paper.
Yes.
So, but I can't remember because
With Blair Stocks, who is now junior faculty with me, one of my former fellows, I have to give him credit.
the good Dr.
He
Stocks,
put the data together.
which is also I love Blair. I've for the past couple of years we've had some of your fellows come up and operate with me, and Blair was a joy to have. He was fantastic. He's such a cool kid. So I say kid because he's younger than me, but he's an attending surgeon now. So you've published that updated data now, but looking in the past, you had previously given men not HCG and FSH, but there was a period of time where you were doing HCG and Clomid, or clomiphene citrate.
Right.
The logic being that maybe the clomiphene would provide a little bit of FSH stimulation.
Right. And you're right. Like, it doesn't give you that much, but it's better than nothing.
It's better than nothing.
Right.
And then that was with stopping the testosterone.
Yes.
And now we've evolved to the point where we're giving actual HCG and FSH on the testosterone, and you're getting the same results.
Right.
Same timeline.
Yes.
That's really cool.
Right. But a couple things to remember. Number one is we don't know, for the most part, what these men, what their sperm quality was prior to starting testosterone.
Yeah.
So not everybody is going to end up being great because 7 or 8% of all men have low sperm counts.
Yep.
2% of all men worldwide have no sperm.
Yep.
So some of those men are going to take testosterone not knowing they don't have sperm.
And a lot of men who come to the table with infertility also have low testosterone. So it would stand to reason that you're going to have some low testosterone patients that in reality have a fertility issue that's just undiagnosed.
Yes.
And then they get testosterone. And then all of a sudden, when you put them on a reboot protocol, they don't come back to fantastic levels because they never had fantastic levels.
I just saw a man, true story, last week, comes in because he had decided, he was like 25, 26. He had decided, look, I'm going to bank some sperm.
Yeah.
So I don't have to worry because I want to take testosterone. I really need testosterone. I want to take testosterone, but I don't want my sperm count to disappear forever.
Yeah.
So he goes to bank sperm and no sperm.
Oh my gosh.
I know.
Yeah.
25. Now he has to deal psychologically with this.
Yeah.
Then he knows he has no sperm.
Yeah. But I mean, I don't think there is maybe a very small silver lining, but knowing beforehand, I think, is much better than knowing after the fact.
Yeah, after you get married and you try for a year and then it hits you, right?
Yeah.
But maybe there's a silver lining to it.
So maybe, yeah. I mean, again, hard journey for him, hard journey for all of our patients struggling with fertility.
No, I agree.
So, I want to tell a little story. Whenever me and
Are you going to be embarrassed?
oh,
You're gonna be
I have
embarrassed?
I have no shame. Yeah, you know this about
All right,
me.
go ahead. What's the
But
story?
and again, I should have no shame because I had a great sperm count at the time. But me and my wife were trying to get pregnant whenever we were in residency, and then it didn't turn out. We had started some fertility treatments, but the timeline just didn't add up, and so we had to go down to Texas for fellowship, and we were trying to establish care at that time, and the the way that I tried to hide it from you at first because I didn't want to impose upon you.
Right.
And I remember whenever you finally learned that we were going through, our own fertility journey, and you got irritated at me that I didn't ask for your help sooner, and you bent over backwards. You got us in with Dr. Gibbons, there at Texas Children's, and you got her in front. We were able to get our medication through Empower Pharmacy, which actually made it financially feasible.
Now,
for
remember
us.
now, for the audience, you were not taking any testosterone. This
No.
was a natural
This
occurrence.
This was a natural occurrence. I was not on testosterone at the time. My sperm counts, were totally normal, but there were real issues when it came to my wife's ovulation and to Sheena. And so we went through a significant amount of fertility treatments that year, but it was successful. And now we've got my 5-year-old son, and then my daughter just showed up later on her own. Don't know how that happens. It's like plugging in a computer, unplugging it, plugging it back in. But that would not have happened just from a timing standpoint if you had not interceded and made that happen.
Yeah, well, that was very nice.
Well,
for you to say that. I mean,
it's true. It's true. So I think about that. Very often whenever I'm with my.
But I think it's also important that you can truly appreciate
Yeah,
the importance of compounding pharmacies,
absolutely.
allowing you to buy the exact same medicine for a 1/5 the price.
I would not. And again, these are not new medicines. They
No.
have been around for hundreds of years because, we originally would purify them from the urine of menopausal women.
They still do.
They still do. They
Yes.
still do. Menotropins still around.
Yeah.
And so these are not novel drugs that companies need to recompense their research,
But what happened?
on.
What happened with that pharmacy? What happened with those drugs?
The FDA, after being lobbied by Big Pharma, the FDA introduced this new requirement of a biologic license, which they didn't give to anybody. And now it is technically illegal for 503A compounding pharmacies and 503Vs to make the FSH and HCG that our patients so desperately need.
Exactly. So all these IVF couples
Yes.
are adding another $7,000 onto their already very high bill to do IVF,
And
just because
And that's for
of the FDA imposing rules that didn't need to be imposed.
they didn't need because there was no threat to patient safety whatsoever.
We have been using those medications for multiple years.
My wife is a living example of. My son is a living example of the quality and the safety of those medications.
And 2 other fellows of mine
Yeah.
did the same thing.
Oh, really?
Yes.
Okay. Oh, that's right. I remembered.
No names.
Yeah, no names. Although one of them you would be fine with it because we're buddies, but it's okay. Yeah.
Well, the other one would be fine too, maybe, but still, it's personal.
Yeah. It's fine. I could talk about my.
But I think the important message there is 3 couples that I just know personally
who were in your fellowship program.
fellows.
Yeah.
And maybe there's a story, maybe there's something biologic there. But anyway,
maybe something in the water.
I don't know.
Yeah.
But anyway, they now have children using compounded drugs for which they paid, just a portion
A percentage of what
of what everybody else is paying.
Yes, and you're very conservative with that $7,000 price increase because that's the cost for couples that are doing a standard course of IVF. But it's much more than that for some of our male patients that may need months and months.
Oh, dear, like you're right.
Yeah, like for some of our secondary hypogonadal patients, that are like Coleman's patients, they require sometimes several months of gonadotropins to get where they need to.
And Klinefelters for life.
Yeah, it's a real challenge. And,
It is.
I will say that it is my dearest hope, again, taking the red versus blue, left versus right out of it, it's my dearest hope that we can get some policy change in the FDA to reestablish access to these medications for patients.
Yes.
Because it's an access to care issue. And if you want to get really tricky about it, that's also bringing back manufacturing to the United States, to compounding pharmacies based here, jobs here, and we can keep that wealth, keep those patients like where they need to be.
I agree. I mean, it's tragic as to what's happened.
It is. It is. So something I want to talk to you about, which is kind of along the same sort of vein of, I don't want to say maybe like gray area or like the bleeding edge of wellness these days.
Right.
Well, I'll take a step back. So one thing that you become extremely facile with is dealing with, I'll call it advanced testosterone management.
Right.
Patients that have come in and taking the same, that are using testosterone, maybe other compounds as well, and you've been very good at establishing a non-judgmental relationship with them, and then also monitoring them to make sure that, hey, if you're going to choose and decide to do this, we're going to try to keep you as safe as possible. And I think that's very noble. I think it honors the same sort of harm reduction that we've accepted as standard of care in the world of addiction medicine and everything else.
Yeah.
And so my question for you is, that's something that's emerged later in your career, and it was
Not asked for.
not asked for, no,
But
but
that just happened.
like how did it just happen?
Well, because I was using testosterone
Mhm.
for the things we've talked about for
Yeah.
people who have very low testosterone.
Yeah.
And there are some people who are born with unbelievably low levels who never go through puberty.
Yeah.
So we have to give them testosterone. So being comfortable writing prescriptions for testosterone,
Mhm.
I started seeing patients who had low testosterone and were trying to get it into the normal range because they wanted to put on some muscle mass, or they wanted to just feel better, or they wanted to run faster, whatever.
Yeah.
But they couldn't do because their testosterone was so low.
Mhm.
So I started treating them with testosterone, and then great results. So they told their buddies come in, and it's a snowball effect.
Yeah.
In addition to which, these patients will be your patients forever.
Yeah.
Because
They
what
love
happens is you also become their primary physicians.
Yes.
These guys do not want to go to doctors.
Nope.
So once they come in and establish a relationship, you become their doctor.
Yeah.
I don't mind that. I mean, now when it gets complicated, I'm going to send them out.
Yeah.
But you know that these people have a lot of trust in someone who's willing to go a little bit extra step for them.
Well, and also it shows that you care about them as a person.
And I
right?
do.
You're not trying to, just check a box, right?
Right.
I think that especially in that space of hormone replacement, I mean, honestly, a lot of the practices that you and I see patients referred from, they treat patients like a number. And it's really tragic because they don't look at what's going on in their lives. They don't consider the individual in front of them.
Right. But what we have to remember
Mhm.
is when I started writing testosterone,
Mhm.
there were not any low T centers.
Yeah.
Or men's health
Mhm.
or longevity, whatever you want to call them.
Mm-hmm.
I don't know what it's like now where you live, but
Yeah.
Texas is unbelievably saturated
Oh, it's come to
with
Indiana
these
too.
low T centers, and they are staffed by mid levels, nurse practitioners, or physician assistants. Not that they don't know what they're doing,
Mhm.
but they don't know what they're doing,
Well,
and they don't have good monitoring by MDs because they'll have 6 centers owned by one MD,
Yeah.
and it's become very much a money making doc in the box situation, although they're not even docs.
No,
They're
well,
mid levels.
yeah, and both you and I love our mid levels.
Yes, I don't want to disparage it.
No, and they are incredible. But one of the reason why our mid levels are so great is because we've invested so much blood, sweat, and tears into their education.
Yeah, I mean, I was just going to say that my mid level, and I want to mention Amy Lawrence, who we all know and love.
Love Amy.
She was with me for 15 years before she went and got her license to become a nurse practitioner.
Mm-hmm.
So, I mean, she knew exactly how I did everything.
Yes.
And she could see patients then as around office hours, but just mimicking what I was doing on the other days of the week. So
Yeah.
I didn't worry that she was going to step out of what I considered proper medicine
Mm-hmm.
because she just knew exactly what to do. And I think when you train your mid-levels to
Yeah.
do what you do, they run with it. I mean,
Yeah, I'm very fortunate. Kristen Gump is our lead mid-level at our men's health center, and whenever she first joined, just due to credentialing issues, she was just stuck to my hip for like 4 or 5 months. And so we were just seeing all the same patients, doing all the same procedures, and so we very quickly kind of learned each other's practice patterns and just kind of set that as the standard. And since then, we've got a training program. China Cuellar is the first graduate of that program who stayed on. She's amazing as well. But we have a very well integrated team where there are frequent touch points. So I know that the care that they give is equivalent to the care that I would give. But when you're one doctor who owns 6 different practices and your specialty is not in men's health,
or even in urology,
or
orthopedics,
or in something, something.
No, it's
random.
crazy.
It's crazy. And so as a result, patients, end up getting treated like a number, and they get the same thing every time, and there's no nuance and there's no deep understanding.
Okay, so I have a question for you.
Yes.
Somebody comes to you.
Yes.
They're already on testosterone.
Yes.
From one of these centers.
Sure.
What do? You don't know what their baseline is.
No
What
idea.
do you do about them?
So usually when I'm seeing them from one of those centers, it's because they're unhappy with something.
Right.
And so I talk to them like, what are you unhappy with? Okay. Are you unhappy with what you were promised versus what you've received? Are you unhappy with the fact that, they've got you donating blood every 2 to 3 months?
Mm-hmm.
Are you unhappy with, some estrogenic side effects? Are you unhappy because no one told you about the fertility side effects? And then once I understand, where the problem is, then we just work together to try and create a regimen that, one, I endorse and support, and also one that helps achieve those goals, whether they're fertility, adding an HCG and
Right.
FSH.
So you see, I went through a stage when I got somebody from outside
Yeah.
for whom I did not establish a baseline.
Yeah.
I would say to them, look, you've got to stop your testosterone. You've got to wait a month.
Oh, and
Then you've got to come back to me. I'll get a level on you. Then I will feel more comfortable treating you.
Mm-hmm.
I've changed.
Well,
Because I've noted, but what I've come to realize is they should not be penalized
yes.
because they went to the wrong doctor.
And the thing is, so many people just choose a doctor based off convenience.
Oh, yes. And I said in another podcast that we do, I don't know if you've seen it.
Oh,
I said, don't go to a doctor because he's convenient.
Yes.
And so many people do. Why did you go to Dr. X? Well, it was down the block.
Yeah.
It's crazy.
I know. It's like we're talking about some of the most powerful medications that
Right.
you can use on somebody, which is why they're so great. But at the same time, like Spider-Man quote, right? With great power comes great responsibility. If you administer these medications incorrectly, you could end up in a bad place.
Yes.
So, right now we're seeing this sort of transformation of testosterone in the mainstream, where all of a sudden it is on every corner. We have all of these different wellness clinics, and the new player that's entered the scene that patients are so excited about are peptides. And you gave a great lecture on this. Can you briefly explain to our audience objectively what is a peptide?
So a peptide is a protein. It's made of amino acids, fewer than 40 per peptide. Once it gets above the number 40 amino acids, it's considered a biologics. And the FDA has strict regulations on how biologics have to be handled. For peptides, it's kind of slipping through the cracks right now. The FDA, no one knows what to do with them because they're a whole new class of medications that people have not used before. The interesting thing is they all come from naturally occurring sources. For instance, one of them that we use for joint discomfort called BPC,
Yep.
it stands for body protective compound.
Yep.
It actually is extracted from gastric secretions,
Yes.
stomach secretions. So someone didn't make it. Someone didn't invent it.
Yep.
They extracted it. Kisspeptin, which I'm very excited about. I've not looked into it yet, but it looks to me like it may have an effect on men for low libido,
Yeah.
which is a huge problem with patients because we really don't have good drugs for that. Much more has been done with women who have hypoactive sexual desire
Yep.
than for men.
Yeah.
But so kisspeptin is extracted from placentas.
Yeah.
So these are not made up drugs. So consequently, they don't have bad side effects that we know of. Now, granted, we're just starting.
Yeah. Early days.
I don't know what the side effects could be, but I'm pretty comfortable right now because there doesn't appear to be any identifiable side effects. And some of them have been around for quite a long time.
Yeah.
For instance, there's a drug called testosterone
Yep.
that's used for mid-body centripetal obesity, obesity around the waist. That medicine was developed for HIV positive patients who tend to, for some reason, put on fat around the midsection.
Yep.
Now, that's been around then for how long? 15, 20 years?
Yep.
But needless to say, this has been an established medicine
Mhm.
for quite some time.
Mhm.
And several other of the peptides have as well. GLP-1s,
Yeah.
the fat loss.
Semaglutide, tirzepatide, these are all peptides.
Yes.
Yeah. And
That people are now taking
Yeah.
with great success. And, no one thinks about it. It's not anything crazy because they're taking, but these are peptides.
those are peptides.
I know.
Yeah.
So it's
And
not like
so is
all-
insulin.
Right.
Shout out
Exactly.
to Eli Lilly back in Indianapolis, right?
Right.
So so right now we have this class of drugs, peptides, that are unique in their composition, they're unique in their end organ effect, and they're also in a very unique place from a regulatory perspective.
Yes.
And so right now, it is, I would say, challenging at best to find compounding pharmacies that make it because of the interpretation of the current do not compound list.
Yes.
And so I think that, we would be ignoring the fact if we would be ignoring reality if we didn't acknowledge that patients are now getting these compounds online from gray market vendors and injecting themselves with medications that may have very poor quality.
Right. So it puts us in a very awkward situation.
Yeah.
A patient comes to you and he's taking a peptide, let's say BPC for his joints, right? That he's buying online
Yes.
and from a big black hole, knows nothing about it.
Yeah.
Yet you
Probably
know,
from China.
Probably.
Yeah.
Yet you know that you've got the ability to prescribe it from a well-established, FDA-inspected pharmacy.
Yes.
So are you going to write that for him? He says, Doc, I don't want to keep doing this online.
Yeah.
I'm really uncomfortable. Can you prescribe it for me? What are you going to tell him? No?
I mean,
And force him to go back to the illegal sources that he doesn't even understand?
And see, I think this is the dilemma that our leaders need to understand, that our goal, do no harm, treat our patients,
Right.
try and get good outcomes. And these are real dilemmas that we face as providers every single day. And, there are some people in our field that have taken the stance of, if a patient is going to take XYZ a dose of testosterone on their own, or if they're going to, use these other compounds, then I'm going to fire them from my practice.
Right.
But I don't think that's caring. I don't think that's the right thing for the patient. And truthfully, you're putting them at risk.
I agree with you.
And so, I think what we really need is access. I think we need broader access to these medications from compounding pharmacies so that we can prescribe them with confidence, knowing that we're going to get the appropriate dose. We're not going to have heavy metal contamination.
Right.
And
They're going to be sterile.
exactly.
But I think the thing to emphasize is there are compounding pharmacies and there's compounding pharmacies.
Yes.
The ones we use are well-established, long-established, FDA-approved
Yes.
pharmacies. They get inspected by the FDA. They come in and inspect them. They check their clean rooms. They check the way they make their medications.
Yeah.
So they happen to be making these other medications because when they come in, the FDA doesn't pull drugs and make sure they're okay. They're checking the facility.
Yes.
Whether they are going,
Are they following best
operating the
practices?
guidelines that they have to.
Are they sterile?
Right.
Or, do
Right.
they have the appropriate
So
safety
the
checks?
patients who are buying it online have no idea
Yep.
who's making
Could be
it,
made
how
to
they're
look
making
bathroom.
it.
Yeah.
Right.
Yeah.
So, and we know that we're getting them top of the line medications for the same price they're paying online,
Yeah. But
And-
with actual quality.
but with actual quality.
Yeah.
So I think, but we're put in a challenging position
Mhm.
right now because of these rules
Mhm.
that have been imposed on pharmacies that don't make a lot of sense.
Well, I'll tell you this: they certainly don't help patients.
No.
They certainly don't help patients, which is ultimately, in my mind, should be the goal of the FDA and the goal of our federal regulatory agencies to protect patients and prioritize good healthcare outcomes.
Right, I agree with you.
That's what separates us from other countries.
Yes.
So, to kind of wrap things up, my question is: you have such a long view on where this field that you helped nurture start has been, where it is today, the forces that have led to that. And so what is your prediction for what we're going to see in the men's health space for the next decade? Like, what do you think is going to be the future for in men's health in 2035?
So I'm going to go out on a limb.
Sure.
I think that eventually testosterone would be used to help people's health issues unrelated to their blood level.
Mm.
I think we will come to realize,
That's a bold statement.
like prednisone,
Yeah.
like steroids,
Yeah.
like non-androgenic steroids.
Glucocorticoids. Yeah.
Yes, that they will find uses
Mm.
that are not dependent on blood levels.
Mhm.
That's what I think.
Yeah.
And I also think that it's inevitable that peptides will be allowable, that pharmacies will be allowed to make them. Now, I'm sure there will be imposed guidelines, as there should,
Yeah.
but they won't be considered outlawed.
Yeah.
One of the problems with peptides is that we would love to have them made by big pharma, by Lilly in but they're a small market.
Yeah.
And it costs these big pharmas so much money to bring a new drug to market. It doesn't pay them under current guidelines to get these drugs made in-house.
It doesn't make sense from a financial perspective. And so that's why there may be a lot of bias against them, because big pharma can't make any money from them. And these may actually help patients live better lives using a compound that big pharma doesn't get any dollars from.
No.
And so there's a lot of
Brave new world.
There's a lot of competing interests out there.
Yeah.
But Dr. Lipshultz, I was so good to sit down and talk to you.
We never got a chance to talk, so this was
this
established time.
I know this is nice,
Yeah.
right? And I just want to thank you for everything that you have contributed to my life, my career personally, and thank you for what you've done for thousands upon thousands of patients of your own, and for the patients of the fellows that you have trained. I appreciate you greatly, sir.
And I appreciate you, and I'm glad that you've become so successful and made me proud.
That we can cut on that. I've made you proud. I've done my job.
Yeah.
Thank you, sir. See you later.